Good morning, everyone. Can you hear me okay? Yes?
Yes, and can you hear us?
Yes, I can. Can I start or did you need a few more minutes?
Yeah, I think it's just 2 minutes.
Okay.
And good morning, Anita. This is Hussain.
Yes, good morning. It's nice to hear your voice. It's a beautiful hot summer day here in Riyadh.
Yeah, it's sunny here as well.
So let me know when you're ready to go. I'm right here, okay?
Yeah. All right, just a couple of minutes.
Okay, thank you.
Anita, I think we should start now. Anita, can you hear me?
Hello, I'm here. My slides. I just got to maximize my slides. Here we go. Okay. Thank you very much, everybody. Good morning. And I'm very pleased this morning to talk to you about strategies for engaging executives and clinical leaders. The objective of today's session will be to look at how we align our vision and actions in our healthcare organizations, how we identify change management frameworks, and examples of leadership accountability that all help to sustain culture of safety and improve patient safety and workforce safety. So, engaging our stakeholders. Definition of a stakeholder is one entrusted with the stakes of betters. So a disinterested, but sometimes a trusted third party, or one who is involved or affected by a course of action. Why is change so hard? Well, because sometimes we're changing our culture, there's a shared lack of vision, misaligned expectations, no urgency, ineffective leadership. And what people resist the most in change, per se, is the loss. Because whenever you're moving from something new to something different, there is a sense of loss. You feel like you're giving up something. It's almost like a grieving process. Just to quickly share a story with you, back home in Canada, when we were going through our healthcare reform transformation, which was huge, and we moved from one organization to a totally new organization with new branding, new logos, new CEOs, and everything was different. Our unit in public health, we had a get together, and we burnt all our old documents, and it was sort of a letting go, reminiscing, and a process of grieving that we acknowledged, and we allowed it to happen so we could move on to a new organization and new culture. So that's just one quick example of how change can impact you in the workforce. So wisdom from Ronald Heath, who is a researcher, a theorist in leadership and change management. And he said the most common cause of leadership failure is treating an adaptive program with a technical fix. And we'll talk a little bit about these two concepts. So what's the difference between the two? So what he says is, in regards to change, is that you have to recognize that the approaches you take to these different kinds of problems that you have, whether they're technical or adaptive, will be different. So, for example, a technical problem is one that's really well defined. Answers can be found, implementation is very clear, and it's easy. It only requires small changes within boundaries that people are familiar with, and it can be usually solved with expertise or with authority, and it's quickly implemented. Whereas adaptive challenges are very much more complex. There's a transformation of long-standing habits and deeply held assumptions and values. There's a loss inherent part of the process. Implementation requires learning and a new way of thinking. It's difficult to identify. It's not that easy always, and people deny it. It requires, a change in values, beliefs, and approaches to work. Requires a lot of changes across many systems and units and boundaries, and it's solved by people with the problem usually. And there's no quick fixes. Requires constant experimental. So it's really important when you're going into the process of change, understanding what your issue and problem is, and whether it is a technical one or an adaptive one. The relevant parties to achieve enduring progress. Oh, can everybody hear me? Okay, good. Said I had a technical problem there. So some examples of technical and adaptive problems. For example, a technical problem is somewhat mechanical. So, for example, a car breaking down, that's the problem. And going to a car mechanic is the solution to diagnose and fix the problem. Breaking a limb is the problem. Going to a surgeon, solution is to realign the limb. And the water leaking in the house is a problem. You call a plumber and you have a solution, you usually fix it. But however, adaptive problems are more difficult to identify and find solutions for as technical fixes are not available. They require people to look beyond the expert for solutions and requires a shift in mindset. So usually a mindset of culture, values, attitudes, beliefs, habits, and behavior. It can take time to identify the problem as well as the solution. It requires new learning sometimes, and new training, new design processes. Some examples of adaptive problems include racial tensions, poverty, climate change, and I would say changing the culture for patient safety. It's, again, an adaptive problem. However, it also, patient safety is an adaptive and a technical problem, because in patient safety, you have to change those values, beliefs, and so forth to create that culture. But some of the things that we're trying to fix, for example, patient identification, or labeling of medications, or preventing pressure injuries. We all have a technical way. There is design processes and technical way of fixing those. So patient safety is really both technical and adaptive. And another example of an issue that is both technical and adaptive is CPOE. It's got technical aspects to it. It's clear, there's tested procedures, and sometimes all you need is authority and expertise to implement it. And it's adaptive because it requires learning, requires systematic adaptive learning involving beliefs, norms, and values, and includes stakeholders. So so it's a little bit of both, and same with patient safety. So that's a little bit about technical and adaptive challenges and problems. So it's really important when you're thinking about change to understand what your issues are, whether they're technical or adaptive, and then it helps you to identify what kind of processes you need to put in place and systems. So why do we need to change our culture? We know that that there's a lot of biggest mistakes of their lives have been shown on the media, have been lead stories, and survivors of medical errors. The article, that was in the United States, as we all know, there's 98,000 people will die from medical errors. So these are all the reasons why we need to look at our culture of patient safety and implement change. As leaders, it's one of the most important things in your role that you would do. So we're going to talk a little bit more about leadership. Carter is another leadership theorist and change management theorist that has come up with this change model, which is very successful for large-scale changes. And we'll go through some of these steps through the presentation. So what he says is that there's 8 steps to change model. One is creating urgency. You're forming a coalition, you're creating a vision, you have to communicate and have a buy-in to that vision, you have to empower action, build that coalition, create new quick wins, small quick wins, build on the change because you want it to continue, and make it part of the culture. So he says these are the 8 steps, and we'll go through each one very briefly. So the challenge of ongoing urgency, that's the very first step that you would take in Carter's change theory. And what he says is 75% of the company's management needs to buy into that change, right? You have to really work hard on this first step. I don't know if you've been watching the Democratic and Republican conventions, but the Democratic convention last week did a really good job of really creating that urgency, communicating that urgency, because that is what's going to get you some of the buy-in. Why is it so important that we have to get this done? And you have to spend a lot of time in this area and build that energy to really recognize the urgency. And then once you have that, it's really important in this step also to identify your threats, develop scenarios, examine your opportunities that you may have, start those honest discussions, and give dynamic and convincing reasons to get people talking and thinking. And request support from your customers, your outside stakeholders, and other people to strengthen your arguments. So if you don't do this properly, you will have a bumpy road throughout, according to Carter. So the next step is building that team, building that coalition. You want to form a powerful coalition because really your human capital is your most vital and critical resource. It's your most important resource. That's where you have your talent. And it's easy for people to copy products and processes or services, but they can't copy ideas. And this is where you get the edge in trying to change your processes, is with those talented people that you have. So he says that, when you're looking at building your coalition, sorry, I forgot to mention, is that you should really look at who are your key stakeholders and ask for emotional commitment. Remember, you got to get to their hearts, not just their minds. There's a saying that says if you can get to at least 60 to 70% to people's hearts, then the rest is 30% is really their brains and their heads. So get to their hearts and build on that team. Do team building exercises, find your champions, and look at where you have strengths and weaknesses and what you need in your team to move forward with your project or your change. The next thing he says, you have to get that vision right. It's really important. The visions that you develop in your organizations, and I'm sure all of you have them, are shared, right? They're not owned by just one person, but they're shared by the whole organization, and there's buy-in into the vision, and it creates commitment. It creates, you know where your goal is, and retains and recruits talent as well. So really help to determine your values. You should have 1 or 2 sentences about your vision, and it helps then to create your strategy based on that vision. And what's really important is that you need to practice your vision speech and make sure that people are very familiar with it and you know it inside out. Here's an example of a Virginia Mason, which is a hospital in the US, and their vision is very clearly identified to be a quality leader and transform health care. So they even put quality right within their vision statement, which is excellent. And we hope that others do that as well. So Carter's 8 steps for successful large-scale change. The next one is communicate for the buy-in. That is so crucial because you can have great visions. You need to, but if you don't talk about it and if you don't communicate it and you don't get the buy-in, then you're going to not be able to really get that commitment and ownership from your staff. So when you're communicating for acceptance, you have to be clear, you have to have those honest conversations, transparency, telling the truth, communication methods, use all the communication methods that you have, social media, I'm not sure if you have, town meetings with your staff, the unit meetings, all your managers, everybody should be able to communicate what you're trying to do and support that change process. Important when you're doing this is to try to remove any obstacles that you may have, right? As you're going forward, make sure that your leaders are there to support you, that they are your sponsors and they're there to have your back and to help you address some of the obstacles that you may have along the way. Again, I about patient
Hello, Anita? Charlie.
Sorry, my internet went off there. Can you hear me? Can you hear
Yes, we
me?
can hear you now.
Okay.
Yes, yes.
Okay, so just about talking about compact expectations. What it is, it's an agreement with that you propose that makes people accountable, but it sets a really clear expectations of what you're going to be doing. Oh, I lost. Okay, there we go. I don't know why I'm losing the internet here. Unstated yet understood. It's a give and take, and it's mutually beneficial. So it's really important part that provides clarity to everybody about the expectations. It's just an example of what you can do within your organizations. It's really important that if you make a lot of, traditionally we've made promises and we have legacy expectations, but it's really imperative that we make it very clear that you want to improve safety and quality. You want to, you say you're going to implement electronic records, or you want to create efficiencies and values and be patient focused and improve access. But it's really important that we deliver on these. And if we promise these are what the expectations are, and this is what we're going to do as leaders, then we need to deliver. And if we can't deliver, it's really important and crucial that we explain to our staff and to our managers and others why. Because sometimes you do get, those barriers that are not in your control. Could be funding, it could be external issues that impact why you can't move forward with something that you were hoping to do. It's really important to communicate the why. Most people understand. But if you don't, then they just think, oh, it's another one of those things they promised, but it never happened. So part of your compact is making sure that you have those clear expectations outlined. If you don't, what happens is you get erosion of morale, slow improvement. People don't, believe what you said is going to happen is going to happen. You get mistrust of leaders who sponsor the change. And it aligns with your vision, so it helps move forward your vision. You need to revisit, make sure it's alive, and reinforce as you go through. Doesn't mean it has to be the same all the way through, especially if it's something that takes a couple of years. Revise it, build on it, and ensure that everyone on all sides is living to the commitments. So Carter's 8 steps. Next step is empower action. So it's really important that one of the tools that you can use to empower action, make people feel they're empowered, they're engaged, and belong, is called the Rapid Process Improvement Workshops. They're really excellent. They help quickly. It's a business process that you can use to leverage opportunities, and you get quick improvements and results, but it requires commitment from leadership. But as I said, empowers people to do their work, and it's part of that quality improvement tool. So you can look that up and learn more about it. Leaders need to be idea coaches. It's not today that you just tell people what to do or you fix it for them. You coach them, you encourage root cause thinking, be straightforward with feedback, and ask a lot of questions. So, but you don't have to be the person that fixes everything. And that's sort of a change in leadership expectations and behaviors as leaders. So Carter says it's really important during your change process that you create short-term wins. And you can, when you're doing that, it's really important that you communicate them. They don't have to be big, just small wins, because it tells people there's action, there's something's going to happen, and it helps to keep people engaged and improve the buy-in. Make sure you have explicit work plans that clearly identify all the deliverables, that you, again, have established those teams and sponsors. You know what your return on investment is, and your board is also aware. Those are really important things as leaders that you need to do. Here's just a quick example of a return on investment. Example, if something's 10 million, you decrease the mortality and length of stay, costs you 12 million, but your fixed costs are, you save 12 million, but your fixed costs are 10 million, you're saving 2 million. So you get a 20% return on investment. Really important to show this to your, especially board and others. So don't let up. Keep at it. Small changes all the way through, incorporate them, set your goals, use your continuous improvement methods, keep your ideas fresh, and build on that change. Don't let up, okay? And then the last but the least is make it stick. Make that change stick. So how do you do that? You tell the stories, you tell the success stories, you ensure that you're communicating all the little wins, you're giving good examples, and you're really important also to create plans to change your leadership, have plans if your leaders change that you have somebody else that can take their spot so that you don't lose momentum through the process. So what among senior executives, there's a growing recognition that a shortage of leadership talent in their ranks is in large part to blame for the lack of progress. So this leads us into talking about leadership and how you have that succession planning and how you build your leadership talent. So talent review guiding principles. Talent is your organizational resource, as I mentioned earlier. Executive leadership is accountable for developing that talent. Assessment of leadership talent is broad-based and supported with specific behavioral examples. And executive leadership is accountable for the ready now candidates. Again, you know, when you're doing a change process, if your leadership is going to change, you need to make sure you have those people that you have been building to take over that change process and continue with the implementation. So this is really important work for leaders to always be doing that succession planning. Leaders' potentials, there's engagement, aspiration, and ability. So those are the three areas that you look for when you're looking at who those future leaders are in your organizations, right? Are they engaged? Do they aspire and desire to do the work, to be involved, to be committed? And do they have the abilities, the characteristics, and the skills used to carry out their work? So those are the skills that you're looking for or the behaviors you're looking for. So leaders' role in signal generation. Leaders are signal generators who reduce uncertainty and ambiguity about what is important and how to act, right? So that's what your staff look at leaders for. You know, they take away the uncertainty. They give you clear expectations, communicate directly, transparency, and all those kinds of characteristics are really important for leaders. Effective sponsorship, they are there to vision of success they want. You want to stretch those goals as leaders. You provide resources, remove those barriers. You fail forward fast, and you celebrate achievements. Don't forget, always celebrate what you've accomplished as leaders, and provide that effective sponsorship to your staff, and know that you have their back. You're there to support them and provide them with the resources as best as you can. Also, it's really important to establish accountability as leaders. Executive leaders provide sponsorship, but they also, accountability can be through compensations linked to the achievement of patient safety goals. You can have middle management compensation that's aligned. Accountabilities are interwoven, no silos that would sub-optimize achievements. You have to have the skin in the game, sort of. Hello, sorry about that. I'm finding that my internet keeps going off. You can hear me though, can you? Hello?
Yes, we can.
Hello?
Yes, we can
Yeah.
hear you now.
Okay, good. It keeps cutting off. I'm not sure why. So again, one of the accountabilities is, the safety and, explaining to your board as leaders about the cost of patient harm and the cost that you can save if you do, look at patient safety. And, when we did the G20 Global Summit and we put patient safety on the agenda, we were able to show the economic burden, over $1 trillion that goes into correcting patient harm. So it's really important to make sure that you communicate some of that to your board and CEOs. What this is I always have to go to my notes on this because I can, it explains that it's a Japanese saying that translates into real location, real thing, and it is a key principle in the Toyota production system. This principle is sometimes referred to as go and see. It suggests that in order to truly understand a situation, one needs to observe what is happening at the site where work actually takes place, the Genba. So this, again, what it's saying is, as leaders, you need to walk the talk. Do leadership by wandering. Go to the floor. Go to your units. You need to really be engaged and be able to know what's happening out there instead of, there's a tendency that people think that leaders only sit in their offices. So it's really getting out there and getting engaged and knowing what's happening in your units, on your floors, with your staff. Okay, so as leaders, it's okay. Vulnerability is okay. You're responsible for connecting the dots. Know your people, let them know you. So go where the action is, guys. Again, what you can also do as leaders to talk about quality and safety is have a dashboard that you present to your board, on a regular basis about patient safety and how you're reducing harm and the costs that you're saving. It's really important to put it in front of them at every board meeting or every quarter board meeting. Tell the story, good and bad. Holding the gains it takes hearts and minds, great people and great systems. The gift of time is a treasure. So again, you want to keep that gain that you've made and build on that momentum. It takes courage. It's worth it. Patients and staff depend on you. Leading change is hard work. Skeptics can become champions. You can turn people around. Patient safety culture vulnerable for CEOs and senior leaders. I just want to talk a little bit about this checklist that was developed by, and I'll show you the example. It was developed by the Canadian Patient Safety Institute, and it was a resource that was put together through a lot of research and a lot of work with a group of people in Canada, and it's what it is. It's about what are the critical knowledge and actions needed to support improvements in safety culture and outcomes that leaders need to take. So here's an example of it. You can find it on the Canadian Patient Safety Institute website, and it really is excellent. It's a checklist as leaders. You don't have to be CEOs or senior leaders, but just as leaders, have a look through it and look at what are some of the enabling things that you can do, what are the enacting things and the learning things that you need to do as leaders to move forward with the patient safety within your organizations. It's an excellent little checklist that I use all the time. And so in summary, engaging leaders. So you need to be a master of change management. Urgency is really essential, a compelling vision, challenge those old assumptions, methods and tools, develop next generation, and respect for people. Remember, people always have old assumptions. Oh, we always did things this way. No, it won't work that way. But you need to challenge that, and you need to demonstrate it and take the small wins to show people how improving patient safety does not just give you better health outcomes, it's cost effective, and it's what you have to do. It's the right thing to do. Thank you. Any questions? Sorry about that internet loss there. I'm not sure what was happening. I hope you have a very great day. If there's no questions, then we'll move to the next.
Thanks, Anita. It's very helpful. Can you share this checklist with us as well?
I'm sorry, I couldn't understand that. What was that?
Can you share the checklist with us?
Yes. Do you want me to send it to you?
Yeah, please. I think that will be very helpful. We can use it in our unit.
Yeah, it's an excellent checklist, and it really just helps with really defining what are the real key areas that leaders need to take to encourage improving patient safety and improving patient safety culture within your organizations. For sure. I'll send it to you.
All right. Thanks. Thanks a lot.
Yes, hello, good morning. Assalamu alaikum. So my
Walaikum
name,
assalam. Lamia, can you hear us?
yes, I can hear you. How are you, Dr. Hussein?
I'm fine. I'm fine. How are you?
I'm fine, thank you very much.
Thank you. Over to you.
Okay, so today, inshallah, we're going today about successful practices for patient family engagement. And as maybe all of you or some of you knows that patient engagement and patient empowerment is related directly to patient safety. It has an aligned relationship to increase patient safety. So that's why we're going to talk about patient engagement, and we're going to go through how is it related to patient safety. So let's start. Our objectives today, inshallah, we're going to describe the research about patient ability to identify errors, and then we're going to examine barriers to patient and family engagement in patient safety. The barriers will differ from area to area, from culture to culture, so it differs, but we're going to talk about the general ones. The last objective is to identify promising safe practices. How can we, as healthcare providers, either we're working in healthcare institutions or we're working on, in healthcare organizations, how can we identify safe practices and how can we promote for better tools? So, patient empowerment definition and components. Okay, since you are all in one room, I would like you to please take 1 minute to write one sentence or a definition of patient empowerment. Either if you can describe patient empowerment in one sentence, in one word, please do so. Even not 1 minute, less than 1 minute, I'll give you. So, from hearing this word, patient empowerment, what does it mean? Okay, so I don't know if you can share with me, or is it too hard to open the mic and talk to me? What do you have in mind? Okay, informed decision. That's good. What else? Who wrote anything else?
Lamia, I will not speak on this issue because so I'll ask the participants to basically say a few things. So somebody said informed consent, and somebody else has said consent. Someone who's aware of his or her rights, ready to give feedback. So these are
That
different things.
that's great.
Engaging, engaging the patients in health delivery process. Patient empowerment. Giving authority to the patient.
Okay, that's amazing. Actually, if we collect all of this together, we'll be able to define it in one sentence. So, patient empowerment definition, it's a process. This is the most important thing. It's not something you can do in 1 day or 1 year. No, it's a continuous process that helps people, not only patients, people gain control over their own lives. So, people, what do we mean by people? Patients, their families, or their guardians. All of these are people who we are aiming to give them the control or to help them gain more control over their own lives and increase their capacity to act on issues. As you said, the right to refuse, the right to speak up, knowing their rights, that they themselves define as important. طيب WHO defines empowerment. They have specific definition for patient empowerment. It's similar to the general one, a process through which people gain greater control over decisions and actions affecting their health. It's not about being an empowered patient in general, it's about being empowered in your own health. And should be seen as both individual and community process. It's not only individual process. So this is the definition of patient empowerment. It's about all the words that you already said. Some of you said informed consent. This is too specific, but it is part of patient empowerment. It's giving the patient the ability to sign something and approve something or even refuse this thing. So what are the main components of patient empowerment? There are 4 main components that have been reported as being fundamental to the process of patient empowerment. The first one is understanding by the patient of his or her role. And this is in most of the countries is missing. So the patient does not know their role. They feel that they are only a customer. They are here to receive the care and then leave. This is not their role. They have bigger role than that. So this is the first step. Patient has to understand their role. Acquisition by patients of sufficient knowledge to be able to engage with their healthcare provider, which is health literacy. If the patient is guarded by their own by the disease information or by the healthcare institution information, they will be empowered by this knowledge to be able to speak up or to give feedback or to whatever the situation is. The third one is having patient skills. It's not only about health literacy, it's also by having patient skills. If the patient have better skills in dealing with some devices in their treatment plan or so, it will help them be more empowered and more compliant to their to their treatment plan. Number 4 is the presence of facilitating environment. What do we mean by facilitating environment? It's not only about the clinic itself. It's the journey from entering the parking spot until having a slip of sick leave. It's all this process is an environment. It's infrastructure environment. But there is another environment, which is policies and procedures. All these environment elements has to be facilitating to the patient. And for example, if the patient has a complaint or even a thank you or something to say or something to report, where should they go to? Some patient does not know where to go to. Why? Because the environment is not very clear or very transparent about where to go or where to speak up or where to raise this issue. So the environment has to facilitate this, has to be more patient empowerment friendly. Okay, so accreditation with engagement and empowerment. And this slide, by the way, I built it as a lecture for Saudi attendees, but it will help you because some of this accreditation is international accreditation. So what type of accreditation do we know? We know CAP, we know, of course, GCIA, and I don't know if some of you or all of you know Plaintree, which is one of the recent accreditations that's been launched globally, internationally. And Plaintree is the most accreditation that cares for patient-centered care. And they have a whole chapter, not only part of the chapter, about patient engagement or patient empowerment. So aiming for getting this certification will help the institution to be more patient empowerment friendly or more patient-centered care. And they have 3 gradings. They have the gold, the silver, and the copper or bronze, sorry. And the one on the top, on the left, it's called Sibahi. It's a Saudi accreditation, specialized only in Saudi. And it has a small chapter about patient engagement. طيب, the question is, now we're going to talk about data, which is a little bit boring for some people, but hopefully I'll go through it fast and it will help you get the general idea about does patient need to be empowered or not? And can patient recognize medical error or not? So this is a survey, a study that been applied on 1,200 patients, and 42% of those patients reported medical errors in their own or by care. So this study shows that a huge number of patients can report medical errors. So they have a huge role if they are empowered enough and the environment is facilitating enough. Another study that is a little bit interesting, or a lot interesting to me by the anyway, they gave 3 questions to different patients and they gave different answers. Each patient gave different answers. The first question was, do you believe that there have been any problems with your care during this hospitalization? This is the first question given to the patient or the family member. The second question was, do you believe that you were hurt or stayed in the hospital longer than necessary because of problem with your care? The third question was, do you believe that anyone made a mistake that affected your care during this hospitalization? And the answers were, one of the answers was, this was a serious adverse event. I had a PIC line put in and I got an abscess. So the patient noticed that they had an infection. They took me down to get surgery. I had a blood clot and they removed part of my vein. So he knows the story. He can report this and he knows that how to prevent this or how to talk to medical team about it. So patients recognize what happens to them. Another answer was, my blood sugar went sky high because they did not give me my diabetes medication. So he knows that there was a medical error or a medication error happened to him by missing a dose. And he knows what was the consequences of missing this dose. So patient recognized. Another answer was, the doctor came in and suggested that I get a flu shot. I am allergic to it. It would kill me. Do the doctors not check patient chart? And this happens a lot, by the way. The doctors rely on the round or rely on the nurse to give him the update. And this is not very, it's not a big issue, but you have to get all the details if you don't want to read the chart. But it is very important to know everything about this patient. So the patient knew that he's going to get a flu shot and he's allergic to it, so he stopped it. This is another study that shows, it was on 661 patients. It's about adverse drug event in ambulatory care. And the patient reports was about the drug event and the ambulatory care was 25%. And both the patient reports and the chart review was 5%. And the chart review only showed 8%. So patient point of view is very important. All these studies shows that patient point of view is very important. What do patients know that hospitals don't? And this question was applied on 998 patients. The patient reports 23%. And both patient reports and chart review 5%. The chart review only 11%. Okay, we will not go through this. Okay, what factors affect patient willingness to take action? So we know that a lot of patients are empowered or have sufficient knowledge, but they don't take action. Why is that? What is the factors that affect the patient or the willingness to take action? The first one is gravity of perceived threat. Sometimes they are afraid or feel threatened, or they are not at the same level of healthcare providers, so they don't take action. The second reason is effectiveness of the action. Are they going to do something about it? I don't think so. sometimes they feel this way. And no, there will be no action behind this report or complaint or whatever. The consequences of speaking up. I heard this when I was working in a hospital. And no, patients are afraid to speak up and they will be discharged from the clinic or from the inpatient. The fourth one is self-efficacy. Some patient does not feel confident or efficient enough. And the fifth reason is staff members' instruction and expectations, because they feel that the staff or the healthcare providers expect something from this patient, so they follow this expectation. How can we promote patient engagement? Okay, do you have an A4 paper, all of you? I hope so. I'll give you 1 minute to set up an A4 paper or any square paper to help you in this exercise. If some of you have, please give to your colleague next to you any square paper, and we're going to do this exercise together. Okay, let's start. So I will give you some instructions, and you will apply it on the paper you have. So the first thing, I would like you to fold. Can you hear me? Yes. Okay. I would like you to fold the paper into. I would like you to fold the paper into half. I'm doing it with you, by the way. Okay. And then I would like you to rip the upper right corner of this paper. I would like you to rip. Okay. I'll wait for. I will repeat what I said because I can see someone distributing A4 paper or square papers. Okay, shall we start now?
Yes, we can start now.
Okay. So
Video. We cannot see you.
okay. I'll open the camera when I'm done.
Okay.
Yeah, but now I can't see you anymore. I don't know if you closed the camera by mistake or something. I can't see the classroom anymore. Okay, the problem is from my computer, so it's okay. Okay, so I'll repeat it. So fold the paper into half, and then rip the upper right corner, and then rip the upper left corner, and then I would like you to fold it one more time into half, and rip the upper left corner, and then rip the lower right corner. Rip the lower right corner. Okay. Are you all done? I see. I think you're all done. So now I will open my paper, and you can see if your paper match my paper or not. Okay. So who has my paper? Please raise their paper up. If you have the same paper I do, raise it up. None of you have the same paper I do? Okay. So what do you think went wrong here? I think the one who opened the mic said, "We can't see you." She was requesting to see me because she wants to know the paper. She wants to know which corner I'm ripping. How many folds do I have? She wants to make sure that she is copying the same paper I'm copying. So I think I'm guessing I can't hear you and I can see the paper. It's not very clear in your hands, but I'm guessing that your paper is not the same as mine. Okay, so what went wrong with this communication? It was one-way communication. You couldn't see me, you only heard me, and you're trying your best to get the same results that I'm trying to share with you. So if you were an empowered patient, what would you say? You'd say, "Open the camera," or "Please show me," or "Which upper corner? What do you mean by the corner? My corner is different than your corner. Maybe you're holding the paper like this, but I was holding the paper like this, or from this side," and etc. So it wasn't clear for you. You were the patients and I was the healthcare provider trying to give you the best message ever. I was repeating, my voice was loud, but you didn't receive the message well. Why? Because it was one-way communication. So I hope this exercise helped helped a little bit. Going back to the presentation, we're going to talk about communication. So how can we improve communication? Now we know that communication is a vital thing in patient empowerment because it will help or destroy the relationship between patient and healthcare provider. So there is something called think stars, and stars, each letter represents something. S represents specifics, T represent treatment, A represent associated symptoms, R represent relieve or provoke the symptoms, S represent severity. So these words are very important to take from the patient. You have to receive it from the patient. You have to receive specific or any treatment they are going, or any associated symptoms, or any provoke of the symptoms or relief of the symptoms, and the severity of pain they are facing. So each specific will help the healthcare provider give the patient better treatment plan. Okay, who knows open disclosure, and do you apply it in your hospital or not? If you know it, do you apply it in your hospital or not? I need an answer, either by writing in the conversation. You don't have to open the mic. So do you know open disclosure? Yes or no? Some of the attendees, all of the attendees? No one knows the open disclosure, which is informing patients and their families of bad outcomes of healthcare treatment as distinguished from bad outcomes that are expected from the disease or injury being treated. So open disclosure, in a simple way, it's a meeting between the patient and the healthcare provider to discuss a bad outcome that happened, which is usually a medical error or a near-miss medical error. So is it applied in your hospitals or not? Do you do that when you do a medical error or something done by mistake? Do you sit with the patient and tell them, "We did a mistake and we would like to correct the mistake by doing that," or you don't do that? Sometimes it's a must. especially if you forgot a sponge inside the patient's body and you'll have to open the body all over again and take off the sponge. But if the medical error is not very clear to the patient, it's not very recognized by the patient, do you do an open disclosure or not? So this is very important. It's all about communication. Open disclosure, it's a very good tool to help patient understand what happened and know their medical history, and therefore act on issues that will happen in the future. And on the other hand, they will forgive the healthcare provider for doing this mistake because they open up to the patient. Not always, but 90% of the time, usually they forgive the healthcare provider. So open disclosure is something that is overlooked, but has to be done in our hospitals. So the key principles of open disclosure, it's openness and timeliness of communication, acknowledgement of the incident. They have to acknowledge that they did this mistake or this error. Expression of regret and apology. You can't tell them that we did this and this is normal. Yeah, patient, this is normal. لا, you have to let them feel that you apologize or regret doing that. Recognition of the reasonable expectations of the patient and their support person. If they have any expectation or any questions or inquiries, you have to recognize them and answer their inquiries. Support for the staff. If your staff, for example, there is a unit head and one of the nurses did a medical error, the head should support their staff, should not just push the staff into this mess and let them take all the blame. They have, you have as a unit head or as a manager or as a CEO, support your staff. And most importantly, you have to make it confidential. Okay, now we're going into the details. So why are we taking this presentation, or why are we talking about all of this? Because we would like to give you some tools that you can implement in your hospitals that can help or improve patient engagement and patient empowerment. So let's go through it fast as a list, and we're going to go through one by one. The first one is family-centered round. From its name, it's a round that includes family. The second method is teach back, and we'll talk about it now. The third concept, it's not a tool actually, it's a concept, a shared decision making. The fourth one is warm handoffs, and usually it is being done in all hospitals all over the world, but it has some obstacle in different countries. Patient and family advisors, patient safety walkabouts, and patient safety caravan. We're going to talk about the first one, family-centered round. Why family-centered round, and why is it important? And what is family-centered round? It's a round that includes patients. But what are the specifics behind this round? So it's a checklist, as simple as that. It's a checklist that includes ensuring that the nurse is present. Why is that? Because the nurse is the closest person to the patient. She or he see this patient every day. So they have to be present in this round. Check family preference of rounds. You will, maybe some of you will say, I'll ask the patient, when would you like me to do my round? This is not possible. It's okay, you don't have to do that. You can do a survey to ask all the patients in the ward, do you prefer AM period or PM period? Maybe most of the patients will prefer AM, and most of them will say PM. Or you can you can ask them, do you prefer early mornings or late mornings, and so on. So including this patient, you don't have to take his word or his feedback into action, but at least you let him feel that he is involved and he has a say on it. So he will be present that time, he will be awakened, he will be listening to you. So because he felt engaged. So at least ask them about the preference of the timing of the round. Ask if the patient knows everyone on the team, because you know it's a little bit terrifying if you're lying on bed and 5 people come over your bed and just start talking. 5, 6, 7 people, it depends. So it's a little bit terrifying. So make sure that the patient knows everyone standing on top of their head in the inpatient. Number 4, discuss with the family. Don't discuss for the family. Discuss with the family the patient assessment and plan of the day. Review and update the goals of discharge. This is very important, the discharge plan. Ask the family and the team for questions. If you're all done and the patient wasn't saying anything or interrupting or discussing, at least ask them, do you have any questions? And then the read back orders. Please tell me what you understood from this round or from this discussion. Okay. Why family-centered round? We'll not go through that. Okay, the teach back method. From its name, teach back method. It's about uh, uh, using this for clinicians to ensure that the patient understood the information. So if you ask the patient to repeat what you said, this is a teach back method. It's as simple as it sounds. Shared decision making. From its name, the concept of shared decision making. What is it exactly? It's a concept that should be implemented in every relationship between each healthcare provider and patient. So it's a key concept of patient-centered healthcare, and it is a process in which clinicians and patient work together to make this decision. Warm handoffs. Warm handoffs, it is the same as a bedside endorsement. I know that most of the nurses and healthcare providers do the bedside endorsement. So the warm handoffs, it's the same. It's the transfer of care between 2 members of the healthcare team where the handoff occurs in front of the patient and the family. So it's very important because it will help the patient understand their treatment plan, their medication, and so on. Patient and family advisors. Each hospital can use patient and family as advisors to help them improve the hospital care or the hospital infrastructure or whatever. So the family advisors can be individual or groups. You don't have to make them as group like this picture. You can use them as individual. So this is one of our advisory boards in SPSC. We use them to help us improve patient empowerment concepts around the kingdom. And patient safety walkabouts. Each hospital does walkabouts every year. Sometimes it includes the CEO, sometimes it includes only the line managers. Those walkabouts should include some patients. It will help the patient understand what the healthcare providers going through and how hard their work is, and how important for them to help those patients. And on the other side, it will help the healthcare provider to see to see what the patient are seeing from their point of view. So it is to have 2 or 3 patient and family advisor participants invited to invite hospital leaders, clinicians, and staff to participate as well during the hospital tour. And this is a takeaway messages. We're done for the patient empowerment. The takeaway messages: patient and family engagement is not a new or separate initiative. It is a critical part of what your hospital is already doing to improve quality and safety. Patient and family engagement improves multiple aspects of hospital performance, including quality, safety, finance performance, patient experiences of care, patient outcomes, and employee satisfaction either. You can start implementing the patient empowerment tools today. You don't have to wait for some approvals or long processes. You can start it today. So it's very simple. Thank you very much. I hope you enjoyed this presentation and you benefit from it. And we'll see you soon, inshallah. If you have any queries, any questions, please write it down, or you can open the mic and we can hear it.
Lamia, thank you very much for a very nice presentation. Um, there is a question about walkabouts. Acha, all right. So any other question? No. All right. Thank you, Lamia. Thank you very much. Very, very nice presentation.
Thank you very much. And if you would like to have more questions, you can take my email from Rakan. You can email me anytime, or even from Dr. Hussein. He has my email. Thank you very much.
All
Hope to
right.
see you soon.
بالماء الساخن. Hello, good morning. Dr. Hussein, do you hear me?
Hello. Yeah, I can hear you. Can you hear me?
Yes.
Okay, thank you.
Thank you very
So
much.
over to you.
Thank you very much, Dr. Hussein. So, good morning again, ladies and gentlemen. My name is Anas Amr. I had been met you last week with the Patient Safety Culture Survey. And today our presentation will be in regards of the patient safety across the continuum of care. And the focus here will be regarding the patient safety issues outside the hospital setting. So the objectives of this presentation, we will describe the main safety risks during transitions of care and main focus for the ambulatory care settings. We'll specify possible interventions to improve patient safety and reduce risk. And we will outline the key elements for an ambulatory patient safety programs. So we'll start with some statistics from different institutions. This slide presents to you some data from the WHO, and I think it's known for everybody, that the adverse events are the 14th leading cause of death globally, and 42.1 million of the hospitalization were done as a result from the adverse event. From those 42 million, 83% from those adverse events leading to hospitalization were preventable. That means we can do something to prevent those errors to reach patients. Again, from WHO, 1 out of 10 hospitalized patients experience harm with at least 50% preventively. If we have a deep look to the United States alone, so according to the new study done in 2017 that studied the cause of death in the United States population, they found that, or they conclude that the medical error which resulted in death and preventable is the third leading cause of death in the United States, which resulted in 251,000 deaths per year after the heart disease and cancer. In Europe, the evidence currently available shows that 15% of the hospital expenditure, the cost in Europe, can be attributed to the treating patients. 15% of the total expenditure, it's went to the treating the safety accidents or incidents. And the most common adverse events which reported in Europe were the surgical procedure with 27%, medication error with 18%, and healthcare associated infection with 12.2%. If you take a look about the LMIC, low and middle income countries, statistics that released from the WHO in 2019, and it's actually shared in the Global Patient Safety Summit last year, 134 million adverse events occur each year due to the unsafe care in the hospitals in low and middle income countries, which contributing to 2.6 million deaths annually. And again, 4 out of 10 patients in low and LMIC, 4 out of 10 patients, 40% of the patients are harmed in the primary and ambulatory settings. Up to 80% of those harms in these settings can be avoided. And the most detrimental errors are related to diagnosis, prescription, and the use of medication. Again, another data that available in the database, this is from Europe again, 1 out of 20 patients or outpatients experience a diagnostic error. And we are focusing here a lot about the diagnostic error. 55% of patients said that diagnostic error were a chief concern in outpatient visits. 1 out of 9 emergency department admission are related to an adverse drug event. And something important here in the right side of the screen, that 80% of information that shared in the primary care visits is immediately forgotten by patient. And this is a complementary to the talk that my colleague Elamia speak about it, about the patient engagement and patient empowerment. Look here, 80% from the information that you shared with your patient, do this and do that, even verbally or whatever you use as a tool, it's forgotten immediately after the patient leave the clinic. A new recent data from the OECD in 2019, which concerning more than 28 focus in the developed countries, they conclude that over 8 billion encounters done each year in the OECD countries, and ensuring patient safety or safety in the primary and ambulatory care is a fundamental policy priority in all countries. And estimates shows that as many as 20-25% of the general population experience harm in those settings in developed and developed countries respectively. The available evidence in those countries estimate that the direct cost of harm, which means the additional tests, treatments, and healthcare in the primary and ambulatory care settings, to be around 2.5% from the total health expenditure. And finally, harm in the primary and ambulatory care often resulted in hospitalization each year. These may account over 6% of the hospital beds. So 6% from the hospital beds are resulted from the harms or errors that are done in the primary care settings and ambulatory care settings. And more than 7 million admissions done as a result from those things within the OECD countries. And again, OECD countries, this is the most developed countries, depends on the reports that came from the OECDs. So actually we have a problem in the outside hospital settings. All the programs and all the patient safety concerns, quality improvement projects actually target some areas for improvements within the hospitals, but there is a little of those improvements or patient safety activities that targeted the patient outside the hospital settings with major focus in the primary healthcare centers and the ambulatory care centers. We'll share with you 3 scenarios here just to highlight this issue. The first one, there is an inpatient with congestive heart failure, has an abnormal finding on his X-ray, chest X-ray, and it's recommended for him to repeat his X-ray within 3 months or in the coming 3 months. She's released home from the hospital, and her primary care physician is not aware about chest X-ray. This is what we call it handover and transition. Okay, there is no integration between hospital settings and outside hospital settings. So, as the primary care physician is not aware about the results of chest X-ray, he's maintaining the follow-up of the visits. The primary care physician is not aware totally about the findings of chest X-ray, and he continue or maintaining the visits. She returned with complication after 1 year to the hospital with advanced lung cancer. Another scenario, a patient with bilateral osteoarthritis of the knee need left knee injection. And this is actually, even in Saudi Arabia, it's not available, the physician offices. I don't aware about Pakistan if the physician offices are common there. So patient with bilateral osteoarthritis of the knee needs left knee injection. However, the rheumatologist performed the injection on the wrong side. And we can conclude here why, because the physician offices or the practice outside the hospital settings, there is nothing done as a tools to make sure that you will perform the right surgery for the right patient for the right side, as what we did in the hospitals or within the hospitals. The last one is the patient prescribed a new diuretic due to the insurance. So patient in the diuretic due to insurance change, and the insurance company did not agree the previous diuretic for this patient, and they agree or give the approval for new diuretic. And the patient take both previous and the new diuretic, leading to dehydration and again further hospitalization. And this is what we call it, or belongs to medication reconciliation, which was not done in this scenario. So why we are focusing the ambulatory settings or ambulatory safety? So most studies of safety in outpatient settings have been done in the primary care settings. Actually, the major of study in the primary care settings, but we should not forget that there is further areas that patient get treated on it, and he can be harmed in those settings, like the specialty practice settings, the ambulatory surgical centers, what we call it, the day surgery centers, for cosmetic, for laser, for something else, dialysis center outside the government side, physician offices, which a private clinic that the physician, they can practice their daily practice on it, nursing homes, and all of us hear about the incidents that happens within COVID-19 in the nursing homes, rehab centers, care in home, including large variety of devices and many others. And actually, we know only the top of the ice we know little about the safety outside the patient settings, and we will share with you the majority of the studies that are done in this regards to highlight the safety concerns outside the patient settings. So, what's different here? Why the ambulatory settings or the outpatient settings, like the primary care centers or ambulatory care centers? What's different here? Actually, what's reported in the literature give us those 5 to 6 points that we can give us a clue to have a focus in those settings. The first one, there is long feedback loop. So what we mean about long feedback loop? It's patient will come to you today, 25th of August. He will complain of the whatever of diagnosis, whatever of chief complaint, sore throat, cold, body ache, oliguria, whatever. So the primary care physician will see the patients and he will give an appointment. He will give the patient appointment after 1 month, 2 months, 3 months. So this is what we call it long feedback loop. So the physician will see the patient at least 1 month for the coming visit. So this is long feedback loop. If the patient prescribed the medicine by the physician, okay, the physician, he cannot monitor the side effects of the medication. But within the hospitals, if he prescribed the medication and there is side effects, so the healthcare team will monitor or will see the side effects immediately. So this is what we call it long feedback loops. And we should focus, if you want to make intervention, we should close these loops and minimize the feedback channel. Care is episodics, like what we mentioned before. Okay, patient will come today and you will give him an appointment after 1 month, 2 months, 3 months, and sometimes 6 months. Signal to noise ratio is low. That means they deal to do with some cases like winter time. So the majority of patients or the majority of customers will suffer from cold, sore throats, slightly shortness of breath. So the treating physician will deal with all those cases as signs of cold. But sometimes there is shortness of breath as a result of the cardiac problems. It's not only as a seasonal. So with 100 cases, there is maybe 1, 2, 3 cases. It's a cardiac origin chest pain or shortness of breath, and this will be missed. So this lead us to misdiagnosis in the primary care settings or in the ambulatory settings. Widely distributed in Saudi Arabia, we have more than, I think, 10,000 ambulatory settings or primary care settings, which belong to the government only. And limited resources, because there is no standards that maintain or mandate those centers to apply it. In Saudi Arabia, we start with the beginning of this year to mandate those centers to go for accreditation. And this is a great push and a great move to enhance the quality and patient safety within those settings. And patient and providers have many degrees of freedom. And that means if I'm as a patient, if I'm not satisfied with this center or with this physician, I have the freedom to change this physician or this clinic or this primary care centers without any connection between those centers. And the IT solutions give us a huge benefits to integrate those old systems. And in Saudi Arabia, we have a movement also to link all those centers with hospitals with what we call it electronic health records. And this will solve this issue. A study done in 2010 by Kester and his colleagues about the patient perception of mistakes in the ambulatory care, and they conclude that 15% of the primary care patients, they reported that physician had made a mistake. So look about the trust relationship between patient and physician, and this led them to leave those centers and seek for further medical advice from different settings. 13% of the population or from the patients reported a wrong diagnosis. 13% of the sample reported a wrong treatment, and 14% changed physician because of the above mistakes. So again, so what do we know about the safety across the continuum? So we know a little about safety concerns that are done outside the hospital settings. And from the literature available until today, there is a focus in 3 types of risky zones that patient can be harmed. And we concluded, or the experts conclude those settings in transition of care, in the medication safety, and in the missed and delayed diagnosis, which have 2-part: test results, follow-up, and referral managements. And actually, those are the 3 cornerstones if you want to build the safety programs in the outside patient settings, like primary care centers or the ambulatory care centers. So an old study done by Forster and his colleagues in 2003, they studied the adverse events after discharge from the hospitals, and they found that 20% of patients had an adverse event within 30 days of hospital discharge. And from those adverse events, 66% was an adverse drug event, and 17% were the procedures-related events. Another study done by Kennan and his colleagues in 2013, and again, they studied the adverse drug event that occurring within the high-risk population with 45 days as a follow-up, and they conclude that at least 1 adverse drug event were identified during the 45 days period in 18.7% of the discharges. And of these, there is 32% adverse drug events serious. That means it resulted with harm, and 5% was life-threatening. More than half occurred within the first 14 days after hospitalization, and 35% from overall adverse event were preventable. That means we can do something to prevent those errors to reach patients. So medication reconciliation is a revolution and a great intervention that we can use it to minimize those adverse drug events. And there is a lot of studies, hundreds of studies that study the effects of medication reconciliation in the adverse drug event. The first study that I want to share it with you, which done with Knippert and his colleagues in 2006, and they're using only a simple technique, which is the phone follow-up after discharging patients from the hospitals. They did a phone follow-up call within 3 to 5 days after discharge, and they found that 29% of the patient, they are not taking a medication on their discharge list because there is nothing done about the medication reconciliation, or they are taking a different dose or frequency, or taking an additional medication. This is as a result of medication reconciliation. So look, within 3 to 5 days, we are not concerning here 30 days or 45 days. Another recent study done in 2014 by Mixonit and his colleagues, they call it the Vanderbilt inpatient cohort study, which mainly a post-discharge follow-up. And they conclude that approximately 50% of the patients or of the population, they are taking 1 or more discordant medication. And it's more common among patients with lower literacy or health literacy, and we will come to have a more focus in the limited health literacy level. So what do you think? What's this picture? Actually, this picture is taken from the physician offices for the purpose of training and education. This is when the physician is going back to seek medical advice for some of the clinic or ambulatory care settings, regardless. And the physician is asking the patient to bring with him the medication that they have it. Imagine how many types of medications that patient have in his own, and maybe he's taking it on daily basis. One simple intervention to do it here is the medication reconciliation. Medication reconciliation, that means revision of all medication that you need to discharge your patient from the hospital settings to be on it within the further period. Another area for improvement, or another area that patient may be harmed in the outpatient settings, is the test pending. A study done by Roy and his colleagues in 2005, they conclude that 41% of the patient had test results returned after discharge. A lot of tests we requested as physicians for the patients within the hospital settings, and unfortunately, patient discharged and he started to follow up his appointment in the outpatient settings or with his primary care physician without knowing the results of those tests that requested within the hospitals. Of those 41%, 9% potentially actionable. That means we need to intervene. We need to prescribe medication. We need to do further tests. We need to have diagnostic tests. Okay, and from the same study, the physician they are not aware about the 2/3 of those results. 12% required urgent action, and 37% required some action. So there is a lot of solution to do it for enhancing the requested test, and we will go through it in the coming slide. But test pending is a major issue that threatening the journey of patient treatment, even within the hospital settings or when he is following up his treatment plan in the outside patient setting. Unresolved medical issues, mainly about the diagnosis. There is a study done in 2007 here by Moore and his colleagues, and they conclude that 28% of the discharges have recommendations for outpatient workups post-discharge, like procedures, endoscopy, or diagnostic imaging tests like CT or referrals. Within 6 months of discharge, 36% of those samples were not completed. So this patient recommended to have endoscopy within 15 days, 30 days, 6 months, 2 months. But actually there is the continuity of care or the journey of the treatment for this patient it's disrupted in some way because there is no connection between the hospital settings about the care plan that done within the hospital system and it's not shared with the primary care physician or with the outside treatment settings. Discharge summary. Sometimes you will say, oh, it's all of those things are documented in the discharge summary. Actually, discharge summary, it's documented. There is a lot of evidence in the literature. They conclude that the discharge summary, it's a poor communication tool. Why they conclude that? Because we are not utilizing well the discharge summary. We deal with it as a routine piece of patient file. Just we will document there the history, the lab test done, okay? But I'm not sure, I cannot interact 100% with you, but if I can ask you, did you document in the discharge summary the pending test that we need to follow, or primary care physicians need to follow those tests that requested for patients? From our practice here in Saudi Arabia, there is a little, because I'm also a surveyor within Sibahi, and we visited a lot of hospitals to assess their readiness for accreditation, and we checked the discharge summary. Actually, nothing written there about the pending test, about the diagnostic test that patient need to follow. Nothing about, but we can enhance this. It's a simple intervention that we can do it here, is to enhance the use or the utilize of the discharge summary. So 2 studies done here, 2002, 2009, and a lot of studies also, they conclude that only 25% of discharge summaries mention the pending test results. So what about the 75% or 75% of the patients that they did for them a pending test, and those results came with something that we need to intervene with it? That means here 75% of the patients maybe have some disease, and this will lead to delay diagnosis, delay treatment, and patient at the end will be helped. And only 12% of the discharge summaries available. This is another issue. There is something disrupt the continuity of care. Only 12% of the discharge summaries available to primary care physician. That means I cannot follow up my treatment plan outside the hospital settings. Here there is an initiative that done by the Gundren and his colleagues at 2010, and they call it One System Efforts to Improve Transition. And actually, it's a multi-year effort to improve both the content and timeline of the discharge documentation. What they did here, they enhanced the content and the timeline of the discharge summary. What this system did, actually, they created key elements. So like a bundle, 1, 2, 3, 5, 10. All those elements need to be checked before patient discharge, and they link it with a timeline. Those elements should be done within 24 hours, with 48 hours before discharge, post-discharge. And all of those elements should be checked, and it should be all or none. All those elements should be checked. And actually, it's giving an example this effort or this trail. It's giving an example of type of intervention to improve again the content and the time. It's simple intervention. They have a bundle, they have elements, and they link it with time frame. It's very easy things to enhance the discharge summary. Just make elements. Here they make 9 elements. It should be checked before patient discharge, like the pre-admission medication list, allergies, follow-up plans, condition of discharge, discharge medication instructions, advanced care plan if applicable, studies pendings or lab test pendings, 24/7 contact information. And this, we have a lot of efforts should be done here. We don't give a patient any information about if he suffer from any things, how he should seek a care in case of emergency, and they focus in the warfare information if applicable. Another examples of those things that focus in the elements or the content and the time frame is what we call the readmission bundle, and the discharge bundles to prevent admission or readmission for the high-risk patients. So again, you can design your own. This is not a matter of ABC. You can design your own discharge summary. Okay, just make it as a bundle, elements, and link it with time frame. This will enhance the revision, the medication reconciliation, the follow-up of the test, and you will give patient access to seek it for emergency or to contact you if he is seeking any medical advice. And this will give a clue or will maintain the patient treatment journey and link it well with the primary care physician after you end with patient in your hospital. Microbiology notification. This is another tool or another intervention that done and studied very well, and it give a good results with minimal efforts. What they did actually here, belongs to the lab. This is basically this is an email notification that went to the discharging hospitalist and the primary care physician of the test results to improve pending test results. That means if the patient discharged and we request him a blood culture, and actually when we discharge the patient, okay, there is no chance for the primary primary physician within the hospitals to see the progress of the patient again. So if those tests was not seen with the treating physician, so the lab will send an email notification to the treating primary care physician within hospitals and the primary care centers that this patient belongs to. So just only design or have an improvement project with your lab and design this simple measurements, and it will add a huge impact to the closing the loops and minimizing the gaps between hospitals and outside the settings. So this was studied, and the percentage of the attending physicians aware of the pending test results improved from 34% to reach 72%. That means around 100% with relatively simple email intervention. So it's a simple email intervention. But using IT, you know that we are in the century of evolution and revolution of the information technology, and we can use information technology to assist us a lot in closing those loops. So electronic medication reconciliation, it's a one intervention, a further intervention to enhance the medication reconciliation. We can, which means that we can rely on the system for the medication reconciliation, and this is studies a lot on the literature. Sknipper and his colleagues, they studied this and they demonstrate that 55% reduction done in medication discrepancies with the potential of harm. A recent study done in 2018 in this regard, which was a systematic review and meta-analysis, which published in the BMG. They conclude that the use of electronic medical reconciliation was shown to reduce the incidence of medication with unintended discrepancies and improve the patient safety. But actually, also we can use it for the post-discharge, pre-discharge, and we can use technology to solve these issues. If we don't have the capabilities to use the technology, we can use it manually also. So I know that, as you know, that sometimes the information technology, it's costly, and not all the institutions able to introduce the technology to for those things. What we can do, so we can use the patient discharge medication education. Just we can design a simple format, what we call it patient discharge medication education. It's similar to the patient family education record, and this is helpful in creating patient discharge medication education, so patient can clearly have lists that say what's new, what's changed, and stop the following. It's a matter of medication reconciliation, but it's manual. So just give a patient this like a discharge summary, but this is specific for medication. Continue use this, stop using this, and this medication is changed, the brand name or the dose from this to this. This is a matter of patient engagement and patient education. And at the end, it's a type of medication reconciliation, and it will not cost you anything. Patient portals for patient engagement, and I think my colleague Lamia, she's covered. She's covering this well in her presentation. And what I want to emphasize here, we have a patient portals, and we did a lot of efforts to design a platforms for patient to be engaged with us or to be partner with us in the treatment care plan. But unfortunately, sometimes I can give you an example. In Saudi Arabia, we have a huge platform for patient engagement, which we call it Maw'id. In English, it's appointment. Actually, it's a patient portal, but it's not utilized 100% to add a lot of features for this platform. It's only utilized for appointment. With COVID-19, it's utilized again for COVID-19 to seek further information about the COVID-19, to seek they share with the patients the signs and symptoms and when they can seek medical advices. So my point here is to utilize those platforms to engage more patients. So we can add to those platforms the medication lists, the problem lists, the lab tests. We can share it with patient discharge summaries, healthcare boxes, health maintenance reminders. You should do this, you should not do that, and medication reminders. So we can utilize the technology. We cannot use it only for single aim. We can utilize those portals to have multiple aims within the same platform. There is a lot of studies done about the engagement of patients within the patient portals. And this one in 2012, the study done by Skrimplet and his colleagues, they conclude that showing patient their medication list in advance of visits can improve the medication list accuracy. So it will enhance the coordination and communication between physician and patients, and it will emphasize the things that my colleague Lamia talk about it, Ask Me 3, if we just show the medication list for your patients. Another area studied, it's concluded that diabetic patients using the portal had increased rates of medication adjustment. And Del Banco in 2012, they conclude that Open Note study, they did something, they call it Open Note, which give the patient the access to see the progress note of the physicians, so patients have more control of their care and better medication adherence if they are given an access to viewing the ambulatory clinic notes. So again, we talk about the adverse event. We will talk about another area or an intervention we can use. We can study it and apply it within the healthcare settings, which we call it the electronic prescribing impact, which actually another area to use the information technology to assist us to minimize errors and patient harm. And this one was studied a lot also in the literature. One study of 15 providers before and after implementation of the electronic prescribing. They found, or they conclude, that the error rate reduced from 42 per 100 prescription to 6 per 100 prescription, just by implementing the electronic prescribing system. And another study done in 2010, which we call it pre-post study, and they conclude the prescription error were decreased from 18 to 8%. And actually in Saudi Arabia, we implement this project or initiatives, and they call it WASFATI, My Prescription. And it's at the beginning, and there is a lot of area for improvements to do it in this side. So electronic prescribing with decision support, we should not ignore the decision support, has high potential for reducing serious medication error. And actually more work needs to be done to maximize the clinical benefits. As I told you, we should utilize the things or the solutions that are available between our hands. We can utilize it for more benefits. We can add a lot of things to be utilized 100%. Non-adherence, this is another major issue, that even if you have the perfect system, you have maintained or you have implemented the electronic health records, and you link the primary care centers with the hospital settings, you are maintaining a channel between physician within different settings, you give the patient the access to be engaged more in the patient portal. If you are not focusing, or if you did not give a concern to the adherence or the literacy level, you will lose those efforts and you will not reach your target. And all the study in 1998 done in US, and they estimates that 125,000 of the Americans die annually due to the poor medication adherence. Imagine, this is in 1998 in US, in developed countries. They said, or they conclude, or they estimate that 125,000 of the Americans die annually due to the poor medication adherence. In 2005, another study done in this regard, and they conclude that the poor medication adherence results in roughly 33 to 69% of the medication-related hospital admission, which cost roughly $100 billion per year. Imagine now, after 15 years of this study, and a lot of studies, they are spoke about this issues, and there is a lot of things to do with by using technology or by enhancing the effort of patient engagement and patient family educations. We can improve the patient adherence to this regard. Another area for improvement, or the patient face it outside the hospital settings, is the diagnostic error. And improving diagnosis in healthcare, this is a very important report, and I enhance you to read it in details. It's available in the website, and it's free of charge. You can use this link to download it. And actually, this is a really important report to highlight the importance of diagnostic error and a lot of interventions that you can start to do it or implement it in your or within your settings to overcome the diagnostic error. So missed and delayed diagnosis is the most frequent type of outpatient malpractice claims by the Gandhi and his colleagues in 2016 in this regard. And also they conclude that 85% of the errors occurred in the physician offices. Primary care provider most commonly involved, with 42% from those errors. And imagine here the median duration of delays was 303 days. When they studied the 200 malpractice cases, they found that the median duration of delays around 1 year to reach the correct diagnosis for this patient and to start the correct or accurate treatment plan. We will go to ABC about the diagnostic process of care within the ambulatory care or within the hospital. Actually, the diagnostic process started with patient. He will notice a problem. After that, he will seek a care. A physician will perform a history taking and physical exam. After that, he will ordering some diagnostic or lab test, and we will follow the performance of tests. Then the test results will come, and we should interrupt the test results. And there is a transmittal of those results. Then we will do a follow-up plan and referral if there is need to refer for advanced care. And finally, patient should adhere to the plan. So actually, this is the diagnostic process, starting with the patient noticing a problem until we have a plan and we ask the patient to adhere to this plan. Any breakdown from within those steps will lead to delay or misdiagnosis. Okay? So where does the diagnostic process break down? Any breakdown from those steps will lead to missed or delayed diagnosis. There is a lot of types of missed or diagnosis in the primary care setting, which documented in the literature. And I will share with you one study, major study, which published in the JAMA in 2013. And they review 119 medical records using triggers to unexpected return visits. So they try to find to collect those diagnoses with the triggers when the patient readmitted. The return visit, that means patient readmitted to the hospital settings. And they conclude, or they found that the most common types of misdiagnosis, imagine here pneumonia, 6.7% from those 190 records, heart failure, 5.7, acute renal failure, 5.3%, cancer, and UTI or pyelonephritis. Those are missed. Patients were not diagnosed with the correct diagnosis, and he's not starting the correct treatment plan as a result of not following the diagnostic process, because there is a breakdown within the diagnostic process. The other side from this publication, also they try to study where is the breakdown happened, and unfortunately they conclude that, or they found that 79% from those problems or breakdowns, it's a problems linked to the history or exam or ordering the test or diagnostic problem with history taking. This is ABCs: history taking or examination or ordering the appropriate examination as a test or as a diagnostic tool for those patients. 80% from the breakdown happened here. That means this is ABCs. So we should not go for the to buy advanced machine, advanced technology. Okay, just we can go back to do root cause analysis to study where is the breakdown happens with the diagnostic process. As you notice here, it's a recent study, it's a major study. Just we share this for learning, even for us, for you, with any other colleagues, that we need to have a more focus in the basics of the medicines. Referral issues, 20% of the breakdown. I refer these patients to the wrong second opinion. Patient-related factors with 16%, follow-up and tracking of the information with 15%, performance and interpretation of the tests with 14%. And actually a total of around 50% or 43% of those population of cases involved more than one of these processes. That means not only the problem with history taking, maybe you can find 2 or 3 factors together within the same case. So failure to follow up tests, again, this belongs to missed and delayed diagnosis. There is a recent systematic review which was done in 2011 by the Karen and his colleagues and in the BMG journal, and they conclude that the lack of follow-up of laboratories ranged from 7 to 62%. 62% there is lack of follow-up, as I mentioned before, and there is lack of follow-up of imaging tests, range from 1 to 36% from the population that they studied. So there is a problem, even regardless of the percentage or the year that this study published. There is a problem with the follow-up of the tests, like laboratory test or the imaging test, and we can improve it with simple measures like email notification for the lab test, or with more advanced intervention like using technology and linking the hospital settings with outside hospital. So failure to follow up, there is a lot of reasons that lead to failure of follow-up. Okay. The absence of guidelines regarding who has the responsibility. Outside the hospital settings, there is absence of the guidelines. Lack of integrated information system. There is no linkage between the hospital settings and outside hospital settings. Multidisciplinary nature of the test management process, because there is no standard there, and need to consider the patient involvement of the test results follow-up. And those are the 4 major issues that we can start to build an action plans to improve the follow-up between hospital settings. So if we talk about referral management, and actually this is an area for improvement, And there is a lot of studies done here. 65% of the primary care physician and 35% of the specialists are dissatisfied or were dissatisfied with referral process. And the source of dissatisfaction is communication, lack of timelines, lack of clarity, and time required to create notes. Electronic referral management, it's another intervention that we can use it to enhance this area, and it's studied well, and there are a lot of results or positive results that done or concluded or shared in this regard that using electronic referral management will enhance the poor referral management. The other settings, actually, as we told you before, there is some areas outside the primary and laboratory care settings, like the home care. And something important or significant that I want to share with you in the home care, the adverse event per client here is 10%, which means high without any outside circumstances. And actually, 56% of the adverse events that done in these settings were just preventable. It's a huge number, a huge percentage, and we can do a lot to prevent those issues. Study done here in 2016 to see why there is an issues done in the office procedures or in the physician offices. And the top barriers where there is no incentive to use the checklist. Nothing it's done to, this is further work, a further burden, and there is no incentive to use the checklist. There is no mandate from the federal or local regulatory agency to use those checklists. Like as previously what I mentioned for you, the wrong side, the procedures that done, because there is no mandate. Non-consuming, I can share with you my personal history. Okay, when I go for a dental clinic, to go to for tooth extraction or to do some procedures, there is nothing done to take history. If I have a hypertension, this will affect this extraction of the tooth. It will lead to bleed. If I have any medication, anticoagulant medication, nothing done. And I can share with you my history. Nothing. There is no questions or no checklist done to check that you have any chronic disease. It will affect the bleeding time, or if you are in the medication that will affect the bleeding time. And they go for procedures. You are bleed, even you are diabetic, not diabetic. You suffer from high pressure, blood pressure, or there's no checklist. Lack of training and time consuming. Last thing that I will go through it. I'm sorry, I'm exceeding my time with 3 minutes. Just I need more than 3 minutes, further 3 minutes. It's what you call it, the limited health literacy. Again, the non-adherence of the patients. It's linked well with the limited health literacy. This was studied in the United States population, and they classify the population of 4 levels: below basic, intermediate, and the proficient. And they found that 36% of the US population were below basic and basic. What does it mean for us, this one? That these patients may fail to understand the critically important warnings which presented in the labels of medication, like an over-the-counter medication. They are not able to understand it. 36% of the US population, they are below basic and basic. 53%, the American population, they have intermediate health literacy, which means that the population can understand well, but they still find it difficult to define a medical term from a complex document about the unfamiliar topic. So that means we should simplify the language and communication between us and the patients. Okay, so what we can do here to engage patient more and to transfer the message correctly, just slow down. Don't be in a hurry when you talk to the patient. Limit but repeat information at every visit. Avoid medical jargons. Don't speak with patient as he have a PhD degree in science or whatever. Okay. Use illustration to explain important concepts. Don't rely only on the verbal communication. Use easy to read written materials. Make visits interactive, and use teach back initiatives to engage comprehension, and a lot of things that my colleagues Lamia share it with you. This is a recent publication that released by the Emergency ECRI Institute, Emergency Care and Research Institution, which is a well-known institution globally. And they released this report with the top 10 patient safety concerns that all healthcare organizations should give a concern to this. And they start, the first one is diagnostic error. This is the first or the top patient safety concern that all healthcare organizations and stakeholders, sorry, they should build an action plan to improve this area. And you can notice here, I don't know if it's clear or no, patient engagement, leadership engagement, and decision clearing, information technology, all of them. That means 4 out of those 10 patient concerns, what we shared with you, it's out from the top 10 patient safety concerns globally. That means we should organize our priorities and start to have an action plan and build corrective action plans to close the gaps or close the loops and minimize the gaps within those healthcare settings. And in summary, primary and laboratory care is the foundation. It's a foundation. It is a starting point. Patient should, when he wants to seek a care, he will go to the primary care clinic. And the key to high-performing, sustainable, and resilient healthcare system. We are starting to know now more about the safety risks across the continuum of care, and we should give special consideration to those areas. We should start to build improvement projects, quality or patient safety projects outside the hospital settings. We also need to focus on measuring and developing the safety culture and infrastructure. We don't know anything about the safety culture within outside hospital settings. Documented transfer is not sufficient across the care sectors, but we can utilize well the discharge summary, okay, and enhance this tool to become more positive tool rather than negative tool. We should focus on systems, and we should minimize the blame of individuals, because we should have a huge efforts to process redesign systems that we have, and we should align with patients' goals and information relevant to care management processes. And all of us know that IT is a powerful tool, but much can be done without or with not IT processes. We can utilize existing tools, we can build further tools, and if we are able to use IT, it's a powerful tool. And stronger governance and oversight is required. We should unify the standards and accreditation, not only within the hospital settings, but we should give a special consideration to the outside patient settings. And this is the time to move beyond inpatient to other settings. And thank you very much. Sorry for exceeding my time with 5 minutes, 6 minutes. And I hope that you get the benefits and start to think about the issues and problems that raised. Thank you very much.
Thank you very much. Hello, can you hear me?
Yes.
Mute here. Anas, can you hear us?
Yes, sure.
Okay, we need 10 minutes break first after 10 minutes. Is it okay to you?
Sorry, I cannot hear you. There is a problem with the voice.
We need 10 minutes break.
Yes, sure. Yes, you can get 10 minutes from now, babe. Thank you very much. Thank you.
Hello? Okay, Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning for us, but good afternoon for you. Can you hear me? Is the sound clear? Okay, very good. Thank you, Dr. Hussein Jeffrey and the team for this activity that hopefully will further our collaboration. My name is Fedwa Bawazir, and I'm the Assistant Director General for Operations and Technical Affairs in the Saudi Patient Safety Center. And it's my pleasure today to share with you some information about the role of health information technology in patient safety and the role of the patient safety professionals in enhancing health information systems towards safer care for all. So the objective of this session is to describe the evolving use of health information technology, summarize the unintended consequences of health IT, identify approaches to improve the safe use of health information technology for professionals, patients, and families, identify the broader aspects of e-health or digital health.
So what is health IT? Health IT systems comprise the hardware and software that are used to electronically create, maintain, analyze, store, or receive information to help in the diagnosis, cure, mitigation, treatment, or prevention of disease. It's not only the equipment, but also it's the software that operates it, and it is effective or works throughout all interval of the care cycle. It encompasses a technical system of computers and software that operates in the context of a large socio-technical system. And this is a very important part, the socio-technical system, a collation of hardware and software working in concert within an organization that includes people, processes, and technology. So technology or health information systems, the IT, the computers, the softwares, the programs that we have, no matter how sophisticated they are, if it's not in sync with the processes and how the people operate these processes, it will not work safely for better care. And some examples of the systems that currently operating in most healthcare facilities: the billing system, the scheduling system, the management system. This is for the administrative ones. And for clinical systems, automated dispensing cabinets, for example, computerized medical devices, electronic health records. It's been widely, even more and more, being implemented in more facilities, especially with the COVID and the reliance of more of online health services. Human interface devices, picture archiving system like the PACS in the most X-ray departments. Again, the broader spectrum of e-health includes telehealth and digital health, wearable health devices. Now, many people have those watch-like devices that they use to monitor their blood pressure, their activity levels, their health status, their heart rate, whatever that they have, different devices that they use to that are related to monitoring one's health. Mobile applications, of course, we have lots of them nowadays. Gaming, and it's a lot used for health educations and how to use gaming to improve skills for the care providers. Artificial intelligence, simulation for training and performance development, again, could be using gaming or other simulation systems that simulate the care and improve the skills of the healthcare providers. Technology, and more specifically health IT, is consistently changing and evolving and increasing in complexity. Now we have the electronic health record or medical record. We have the radiology ones. We have those systems in the lab that links the machines and the input with the output, that it goes linked directly to the patient file. Pharmacy, they receive the order electronically. They prepare it and they enter the information and the labeling and everything that goes through the e-system or the health system, and many, many more. You have the teleradiology, home care. Now it's even more enhanced. It's safer for patients to stay at home, and then we try to help them and visit them or use e-health to monitor the home care services. Telemedicine for consultation, especially professional and professional consultation with in vast countries, especially that you have the larger facilities condensed in the capital cities or the main cities, and you have people in rural areas that it may trouble them to travel. And having telemedicine facilitates a lot for this professional consult, and it eases the expenses and the cumbersome process of traveling and moving a sick patient. Integration, of course, business intelligence, client relations management, patient-doctor engagement, and the mobile apps, and we have the call centers. These are just like how complex, and it gets more and more complex as we depend more on technology. Patient safety and digital health both were in the 2020 G20 agenda. You may have an idea that Saudi Arabia is the host for the G20 this year. And these two, hand in hand, are included in the agenda with the objective of optimization for health economic benefits and improve access for universal health coverage, improve healthcare data governance to improve utilization while maintaining privacy. And this is very crucial area because as the pace is fast, policy and national regulations are not coping as fast with upcoming technologies to make sure that there is some safety check to make sure what are the measures taken in different countries to maintain privacy, plus the safety of all these different apps and technologies coming up. Patient safety in a digital era needs a lot of governance clarity in balancing both access and actually making sure that it's safe. And recently, we've had a collaboration with an entity that they created a chatbot that is an app that's going to be on a Google app. And it was interesting, and it was warming for us to know that actually for health apps to be included in the App Store for Google, that they needed a governmental entity to approve, a relevant governmental entity to approve the content and the safety of this information to be available in the App Store. So this is really good. Assuming it's the company's policy. However, we don't know if it's implemented everywhere. Data and information sharing, again, this is a key thing. Now we are living in a global village, so information sharing now with COVID, it's a big example how this information sharing about the vaccine and what's happening with this virus, and how transparency versus the autonomy on this technology and inventions and the creation of new vaccines need to be transparent across the borders, so it benefits all humanity. So what are the background or the benefits and challenges for health IT? If medicine is to achieve major gains in quality, it must be transformed, and information technology will play a key part, especially with respect to safety. And this has been published since 2003, that these, like, improving health quality will be influenced big time by information technology, and having in mind that safety has to be maintained at all levels. So some of the benefits that we have access to a broader group, patient groups, through e-health and through digitized health. Improve compliance, especially in younger population, because a lot of the younger population, they like this using technology and having the apps, and very much linked to their phones, and how we can optimize this. Like, many use them, they find it easier if they just can access it on the phone, and they can comply more to their physical therapy regimen, their medication regimen, different treatment plans. It saves time, definitely, because it's very handy, very accessible. There is no commute time. There is no data transfer time. It's an immediate, real time. Empowering patients, because patient has access to more of their information than before. And in some countries, they're implementing the patient-initiated health record. So as a patient, I can open a health file within a healthcare community center, for example, and I updated as I monitor my own activities, my own clinical treatments that I need, or even my habits that may be linked, and this can be accessed by my care provider whenever we have an encounter or a visit. Whether it's physically or online, then the care provider can monitor the lively activities that this patient has been doing, and how it influences his or her health decisions. For diabetic patient or hypertension, hypertensive patients, this information is crucial because if it is current, and then interventions can be indicated. It improves communication among clinicians and care providers. Customize healthcare students' learning, definitely, because the data is there and available, and many real-life scenarios can be extracted to create learning for the students. Enhance research and data utilization for wider benefits, of course. And in this short period of time, there were a lot of COVID-related research because most countries depended on electronic application and real-time data that it enhances the research. Regulatory agencies' response to safety concern with health IT, of course, as more and more automations happen, regulatory entities are more concerned about how the use of technology may affect or prevent, for example, sentinel events. Like the Joint Commission had 2 sentinel event alerts related to health information IT, one in 2008 and one in 2015. And the US Food and Drug Administration also has a Safety Innovation Act to make sure that considering health technology as one of those health products that needs to be regulated. So a Joint Commission has an interesting conclusion that I think it hit homes with all of us working in the healthcare sector. The overall safety and effectiveness of technology in healthcare ultimately depends on its human users. So no matter how sophisticated the system is, if you have not well-trained, oriented user, it will not provide or deliver its expected outcomes. Any form of technology may adversely affect the quality and safety of care. Not only must the technology or device be designed to be safe, it must also be operated safely within a safe workflow processes. And this relates to a lot of hospitals that are leaders or managements that thinking, if we automate, all the problems will be solved. We will not have this pitfalls or that pitfall. Or, for example, incident reporting. If it's automated, then we'll have more reported incidents. And that's not necessarily the case. Because if we don't have a proper, well-tailored flow that is manually tested that it's working, automating it will not solve the problem of it not being a sound process or system or well-implemented system. Electronic health records introduce new kind of risk into an already complex healthcare environment. Definitely, it's one of the most complex environments to work in or to be served at, where both technical and social factors must be considered. We cannot look at the technology in separation from the humans that are going to work on it, and vice versa. Here are some of the a few or a number of health apps that were found in the app stores. Some are related to VTE or the DVT, which is one of the essential safety requirements here in Saudi Arabia, and there were national efforts to eliminate this harm. And there are many more. Some of like government issued, like you see the one in green in the third box or the first box from the right. That's Sahha. That is a government issued MOH app where patients can log in and register and access clinical consult or complaints or different services through it. There is another one with a checkpoint. This is specifically also used during the COVID time, that you do an online screening, and then based on which they advise you to go to a testing center, and then you receive the result through the app, and they send you a lot of health alerts that are related to COVID and non-COVID as well. And these are just some. And with COVID, we had even more specifics, like from the WHO or for us here nationally, we have different tracking apps that alerts you if you have been encountered with a patient who tested positive. And I'm sure there are many more. So how do we help make sure that all these changes coming from technology, that they stick and they create a more reliable performance and more safe care environment? So in this graph, you can see there are elements on the left, that is individual reliance, system reliance, and reliable performance. So this is how we work. It's each individual of us create the system that hopefully it's a reliable system. So how do we increase reliability throughout this? So we have education and information, rules and policies, checklist and double check systems, standardization and protocols, automation and computerization, forcing functions and constraints. And how this, in reality, we could do this. This is an example for medication administration. For example, for education and information, we have the references. We have different references that pharmacists and care providers refer to. For rules and policies, the rules are clear, like RNs manage all infusions, for example. Checklist and double check system. So two nurses check all pediatric medication doses. Standardization and protocols, high-risk medication protocols are created. Automation and computerization, electronic medication administration records. So you have this electronically available. And within that, you have the forcing functions and constraints. So there is a barcode-enabled medication administration, BCMA. So without using the or scanning the barcode, you will not be able to administer this medication. And this will eliminate wrong patient, hopefully, if you identify the patients correctly and so on. And this is a clinical example about for medication administration for forcing functions. However, if you think of other administratives like patient registration system, for example, and how patient data is entered, forcing functions, you need to make sure that is audited and well implemented, because otherwise you might have some who might cheat the system or create their own shortcuts. We found it some in here when I used to survey hospitals, and we can see like some, because they want to expedite the service, and during registration, for example, if there is a forcing function that you have to have a next of kin data, they can just cheat the system and skip that step. And we have to audit this, because otherwise we can't really identify if this system is providing what it should be, that is accuracy and correct identification of patients, for example. So Institute of Medicine report urge healthcare providers to adopt healthcare technology to improve patient safety. So in the crossing the quality chasm, a new system for 21st century, there is this equation that was that stemmed from this paper: knowledge-driven technology towards improved outcome. So what is the knowledge-driven? Like we have the clinical judgment, clinical data display, order sets, test view groups, rules, alerts, reference materials. As we said, like we need to have the base. And then we need to optimize by using technology, clinical information systems, and applications. And hopefully it will improve this the care, we having it safe, effective, patient-centered, timely, efficient, and equitable. So what is clinical transformation? We can't talk about technology without transformation. So the clinical transformation involves assessing and continually improving the way patient care is delivered to all levels in a care delivery organization. So it has to be, it's a continuous process. And it rejects existing practice patterns, because if you're happy where you are, you won't be making any effort trying to transform the clinical services that you provide. And having a clear goal or common goal for patient safety, clinical outcomes, and quality care through process redesign and IT implementation are key to make sure this transformation happens. So we need to blend people, process, and technology. We cannot look at each separately. Clinical transformation occurs across facilities, departments, and clinical fields of expertise. So what is the role of us as patient safety professionals or officers and the health information technology? So patient safety leaders have specific responsibility. We have a role in the selection, implementation, and maintenance. And unfortunately, in many care settings, they are not included when they're trying to see their health information needs assessment process before investing in, even whether it's in-house built health information system or purchased. And of course, purchasing such a program isn't cheap. Many times you find the patient safety risk managers are not really included in the process of assessing the needs and what the systems need to fulfill. So it's very important that the patient safety officer establish patient safety goals related to the health information technology implementation. I gave an example earlier about patient identification, and definitely barcoding and the info system needs to make sure that patient demographic data is well captured. You come to another goal that is improving communication, for example. So this is the medical record, or the health record is the platform where healthcare providers communicate, and its accuracy is very important. We used to have thorough health record, medical record reviews by the medical record analyst or by the medical record review committee or the M&M committee. They all review physical records very thoroughly. And the challenge is to make that habit also carried out to electronic medical records, not thinking because it's electronic, meaning all entries 100% accurate. And how do we create triggers or flags in the system to make sure patient safety goals are addressed and flagged and identified? Define a measurement strategy for each phase of health IT adoption to understand impact on patient safety. We need to be involved and to make sure that is this automation is going to create some shortcut that might impact patient safety negatively, or is it going to be a positive impact that we need to enhance? Assure the organization realizes sustained patient safety benefits from the health information system. Protect patients and organization from unintended consequences of health IT implementation. Sometimes we're just so focused on that this system is going to be state of the art, is going to make our life much easier and so on, and then we oversee some unintended consequences that might occur, side effects per se. Establish patient safety goals related to the implementation, like defining measurable impact on error rates, including errors of omission and commission. Define measurable impacts on timeliness of care. Is it their delay? Is it causing any information gap, information transfer between the care providers? Again, part of the measurement, having quantitative measures can come from safety data, such as event report, publicly reported measures, or timestamps from the health information system. This is the output of the system that we can use to measure. And then qualitative measures can come from user survey report. How do the users find it helpful? Does it really serve what it's supposed to be? Are they comfortable using it? Does it address all their needs? And so on. So what are the changes related to HIT when errors occur? So when we talk about individual error as a systemic error, along this spectrum, there is a direct caregiver, and there is the policies, procedures, technology that affects a systemic error. So HIT is often designed to mitigate individual errors that at the sharp end of the care. okay, because that's like the direct interaction between care providers and the patients. And it creates systemic errors at the blunt end of the care that have the potential to reach many patients. So it's more global. Additional error mitigation strategies may need to be added to blunt end processes to make sure that it doesn't reach the sharp end, doesn't reach the direct patient interactions. For example, if we go back to the barcoding medication administration is designed to prevent nurses from giving the wrong medication to a patient, right? So we focus about this individual side, that is the patient nurse interaction. Incorrect barcode labels attached to a batch of IV bags in a pharmacy could cause multiple IV medications to be given in error to multiple patients. So that's more of the systemic, the blunt end of it. Scanning the barcode label after IV bag preparation added to the pharmacy process to verify correct labeling. So this is where we make sure that it's added to the system that the no wrong IV bag goes to the wrong patient. This is another example of measurement of patient safety impact by phase of the IT development. So the health IT development usually has these stages, implementation, like project milestone, and then the early use, utilization of statistic. Is the health information technology being used to the extent expected? If not, how do we improve the utilization? Stabilization and compliance. Is the health information technology being used as designed? If not, improve compliance. Because sometimes you have something very sophisticated and yet it's not optimally implemented or adapted or used. Adoption, like how do we have averted errors? If not, we need to review the design decisions to make sure that it did prevent errors. And the completion, safety, return on health IT investment. So has the information technology realize the safety improvements that we require from it? So how do we double check on this? So in the same example of the barcode medication administration, so we had the project milestone, it's implemented, then we need to review the statistics. Is scanning percentages. How many times do we scan the barcode of the patients before administering medications? The compliance, we need to do some walkarounds and do observation of the scanning process if it is implemented. What are the statistics of medication error, especially related to wrong patients, wrong medication administered, or omission of medication? Any medication error related statistics need to be looked at to see, have we been consistently implementing the system to avert any errors? And then we need to evaluate the decrease in severity of the medication errors or change type of medication errors. Maybe we have now a different type of medication errors once we implemented all this automated system. So we need to, once we identify the measurement strategy, we need to assure the organization realizes sustained patient safety benefits, establish utilization matrix that can trigger management review and interventions to assure optimal utilization of safety technologies. So it's very important that we monitor. We have triggers in place proactively to make sure that what we want from the system for to serve safer care, it is met. Define patient safety committee oversight of utilization and outcome matrix. So once we have this data, it has to be reviewed, it has to be seen, decisions need to be made by a multidisciplinary team. Assure feedback mechanism is established between users and the health IT experts to continuously improve the technology and clinical process. We need to protect patients and organizations from unintended consequences of the health IT implementation, assure adequate feedback and reporting processes exist to reflect both expected and unexpected impacts of the technology on the processes and outcomes. We really have to audit. We need to have an openness. It's like we don't want to be the management that felt we invested so much in this technology and we don't want anyone to say they're not happy with it or that it's not doing what it's supposed to do. We need to make sure that it does what it's supposed to do, and it is making sure that care is safe. And we need to listen to the users because they're the ones on a daily basis, and we need to monitor more of the front line using the system, making sure there are no shortcuts, data is adequately entered, and it's sufficient. Qualitative accounts from users are valid sources for information for evaluation of unintended consequences. That we need to, of course, involve patients and families, and they need to participate in the evaluation. One of the feedback you might get that the doctor is always looking at the screen and is not looking at me when I'm talking to him. That's an unintended consequence of the sometimes focusing on entering all information in the health record, that we forget to do an eye contact with the patients, which may result in lose of trust, because if you don't look at me when you're telling me what to do and when I don't feel you're listening to me and the problems that I'm coming here for, why should I trust that the treatment plan you're giving me is the correct one? I may not adhere to it. So this is something that you've seen and you may hear from patients, and it's very important that they participate in the evaluation to make sure that at the end, all this is to serve our patients. So we want to make sure that what is it in the technology, maybe like accessing certain services from home, or the automated appointment system, for example, checking the results in a timely manner, having timely consults, and so on. So this is an example of unintended consequences can occur in every phase. So for example, during implementation, we may have anxiety of errors from inadequate design, training, or support. We may have interruption in work processes and team communication, loss of situation awareness. For example, we are not among the early users. They may be like, so what is it exactly? Are we hybrid? Are we migrating to fully automated? What's happening? Persistence of previous processes alongside the new one. There is unlearning step that needs to be done by discarding the old ways and making sure the safe new ways are implemented. The adoption, we need to monitor it through workarounds. The workarounds around, as I said, sometimes we want to create some shortcuts or cheat the system, skip some data elements. How do we, if this forcing function, how do we comply with it, or making sure that it's complied to correctly without anyone trying to work around it? Completion would be the failure to address special patient population needs. We need to make sure that whatever the system is, it addresses the type of patient we are serving. So not all unintended consequences are errors or are problems. For example, here when we talk about the e-medication automated barcoding deployment, for example, the dose filed accepted scanner input, allowing the 11 to 13 digit NDC number to be inputted into that field in error. So the result was erroneous patient record and patient charges. Because of that, the system is allowed 11 to 13 digits. Positive consequent barcode verification eliminated the verification for some medication because you do it once and it's already computerized and systemized. The deployment of health information technology should be thought of not as a single event in time, but rather an interactive process that requires modification and improvement. So what is RCA square? I think you might have attended the presentation already, part of the PSO course. So we can have automated root cause analysis. When safety events occur, the HIT solution are frequently involved. Sometimes as a result of what is the root cause, then we choose automation to be one of the solution. A thorough and complete root cause analysis is needed to identify which components of the socio-technical system contributed to the event. So we need to make sure that the root cause analysis process could identify what is really IT related and what is the human side of implementing the technology. Common health IT related problem is definitely, it's not a guarantee. While the interface between delivery of medical care and IT offers significant benefit, it has raised concern of potential risk to patients. Facilities should not implement health IT without fully understanding the operating environment of their system. How ready are the staff to move from paper-based health records and processes, manual processes, into a computerized system? What kind of preparation, orientation, computer literacy? Now we assume everybody with a mobile, meaning they are tech savvy, but that's not necessarily the case. We still have people who prefer manual processes. They have better trust because of maybe the news they hear about hacking or about people being monitored through different IT systems. So you will still find people who are not comfortable with full automation. So some of the human-computer related issues: a patient was not identified properly and all clinical information was entered into the wrong record. That's a possibility, especially if medical record number is not strictly followed in terms of it's issued uniquely to each patient, plus that it's double-checked and verified. Data were entered incorrectly into the electronic record due to multiple records being open. Sometimes we have different windows on the desktop and people just navigate through multiple records and it may enter the data in the wrong file. The system failed to alert the user of an identified concern with a flag or a pop-up, for example. And this is a lot of systems now have this facility. They ask you when they're building it, what are the kind of flags do you want? For example, the MRSA, that was one of the flags that we had in our health records where I used to work. And some infection control flags were included as well. Falls, for example, risk for falls, and so on. The user ignored or overrode an alert. And this is about the alert fatigue again, when you use the automation and then you enter a space and it's all kind of alerts are happening and you kind of just override them. Data were not entered into the system. That's, you missed a step altogether. Data were incomplete and missing from the entry. Computer related could be data were not displaying properly in the system. The network was down or slow. Interface issue with the laboratory system caused delays in the ability to retrieve data, for example, because lab machines have their own, and usually like they talk to the system that the hospital has adopted to, and sometimes there are some problems with data transfer. The software was not up to date. Software did not meet the needs of the specialty provider. For example, it's just too general, that doesn't fit the different specialties and subspecialties that are provided in the hospital. The software was not functioning properly, or data were lost. No proper backup process, for example. There could be, this is a case study for computer-related. A physician ordered a patient's anticoagulation medication to be discontinued. The order did not cross over to the pharmacy system. The patient received 8 extra doses before medication was discontinued. Okay, this is an example. Another case is with the software configuration and function. The system prevents the nurse from typing more than 5 letters in the comment field, which is causes missing information. For example, an influenza vaccine order does not drop off the active work list after it is given. This is again a software problem that could happen, and so on. Could be wrong data input again, and could be wrong record retrieved. IT and diagnostic errors, there are plenty system-related factors contributing to diagnostic errors in 65% of the cases. And improving test result follow-up through electronic health record requires more than just an alert, because you need the clinician to look into it. So it's not just simply an alert, how we can improve this. Improving information overload and missed test results in electronic health record-based settings. Also, these found of part of the diagnostic errors related to IT systems. Here is an 8-dimension of socio-technical model to use to evaluate the current situation or the system that you are implementing. And it has these 8 steps: hardware and software, clinical content, human-computer interface, the people side, workflow and communication, internal organizational policies, procedures, environment and culture, external rules, regulations and pressures, system measurement and monitoring. And it's very useful to step back and evaluate what's happening from the information technology perspective to make sure our care is safe. And this is a suggested checklist. So this is an example, a case study. In the laboratory, critical lab results were overlooked without full interference for different health IT systems. So consider the following properly designed health IT system interface that hindered the reporting of clinical laboratory results to patients, physicians, and eventually led to a fatal event. So this could be a sentinel event that happened through this. So this is how you can implement that side, the 8 steps to evaluate what went wrong. The system lacked an effective two-way interface between the lab and the organ transplant program for ordering tests and receiving results. So that was an organ transplant case. Test results were not stored in a structured format. So this is when we're talking about the clinical, the hard-end software, that's the lack of the interface between those programs. The clinical content, the test results were not stored in a structured format to facilitate reporting and tracking of the data. For human-computer interface, clinicians could not review test results in the patient's medical record, and there were no alerts prompting clinicians to look for critical results, and this is very crucial factor. For the people, transplant staff created workarounds on an effective system interface. Apparently, there were some shortcuts that were created. Workflow and communication, there were no fall-safe measures to ensure that clinicians receive the critical care results. There is no double checking, or there is no backup or plan B for when the automated system doesn't make sure that the information reach the intended clinician. And then we have the organization either failed to develop or enforce the policies. There is no clear policies or password sharing, name it, could be many that relates to policies and processes. Some of external rules and regulations, although the event report did not specify any number of external pressures directed to the staff, such a compliance with federal meaningful use of laws, regulations, preparation for accreditation, and so on, is actually very important to addressed, to be again, when we talked about data governance in the beginning, like we have all these kind of systems, there are some laws, regulations, accreditation, expectation that we need to make sure they're in place and they move fast enough to make sure that all the speed in digitized healthcare is addressed and regulated. The organization failed to monitor laboratory test results follow-up to determine whether critical results were received or not. This is a system measurement and monitoring. So these steps were used as a checklist to see the case. So you follow the case flow and each against each this, and they found these findings that are around this this graph or this cycle. This is again how the automated method to identify wrong patients could save a lot of time. We can retract and reorder in real time. This is also again the checklist for test results reporting and follow-up, how you can use it to evaluate. So again, the HESTA IT and patient safety officer. So we want to make sure solutions will continue to happen. Point solutions such as the the barcoding medication administration will begin to be integrated into the barcode network of solutions. Patient safety leader plays a key role in evaluating health IT solution, and implementation plays using the failure mode and effect analysis, which my colleague Mr. Muhammad will take on after this. The framework discussed in this module, monitoring the effective use of the technology and evaluating safety concern related to technology. We need to be proactive. We don't want to be surprised that, oh, we thought automation is going to solve this problem when actually it didn't, and create more problems. Definitely, we thought like health IT solution works with all this medication errors or legibility of medication requests and orders. In summary, health IT is effective in reducing variation and improving reliability in a broad area of clinical processes. There are plenty that have been automated. Health information tools invariably highlights unappreciated gaps in current processes and required interactive stages to realize the full patient safety benefits. Definitely, it helped us when we automate, we scrutinize our processes more, and we try to make sure that patient safety benefits from the automation process. It's not just to make care faster or more or much easier for the provider or the patient, but we might want to make sure safety is maintained at all intervals. The HIT tools are also moved to potential errors for a new point in the process. Data governance and HIT guiding policies to guide health information technology or the digital health. It's very important that we have rules. I'm not sure if in Pakistan you have laws that are clearly guide the different implementation of digitized healthcare, or for example, the apps that are coming up, how are they governed, the information sharing, maintaining privacy and all this. I'm sure there are some laws. And I find it like in most countries, maybe when we talk, is they have the global and the focus on the privacy, but when it comes to coping up with the technology, for example, in the G20, when we had the side events about digital health, and we talked with the different countries, that is the aspect addressed, but there is no clear country level laws that to make sure it's not just simply anybody creates an app can simply post and say that this app is useful or good for you. So how do you make sure that the content is clinically sound? Who is a scientific entity that is actually approved to make sure these contents are happening? Again, the monitoring and the audit of the electronic health record at hospital level, how critical, how thorough, and to make sure that all these are guided. So if you have any questions, I think I have 2 minutes. I hope you have found this relevant and practical.
Can you hear me?
Yes.
Padma?
Yes, I can hear you.
Okay, Padma, thank
But I
you so
cannot
much.
see you.
And if you have any questions.
Okay, thank you.
Okay, thank you.
Hello, Hussein. Do you hear me?
Hear you?
Can we move to the new link, please?
Okay.
Okay, thank you.